Textbook here. This is a textbook. It's called Pathology for the Health Professions. There's multiple editions. Right now we're on the 6th edition. If you go on Simpson's library, we don't have the online version of the most up-to-date book. We're trying to get them to get that for us. But there is the 5th edition. So it's a good resource because, like I said, everything that comes out of this lecture is going to come from this textbook. And it has some level of detail. Sometimes it's missing some stuff, I think. But it does go into more detail on some things. So if you want to read the book, you want to get more information on it, you can. Now I will tell you, I'm not going to ask you a test question on something in the textbook that I didn't cover. So take that for what it is. We have the slides. Everything that you're going to be tested on will come from the slides. But again, it's just that extra level of detail if you want to read more, which I didn't want to when I was here, but you may want to. Must have come to this. Let's see here. So the course goals, like I mentioned, we're going to just kind of introduce you to different aspects of what you're going to be seeing throughout the rest of the semester. And it's kind of hard, right, because a lot of you come from different backgrounds. When I came through here, I was a medical lab tech, so I had a lot of knowledge on lab stuff, but nothing as far as different diseases. I didn't know how to take a patient history or whatnot. Some of you come from those backgrounds where you've seen patients, you've treated patients. Other people have not done anything medical. So for some people, this is going to maybe feel too slow because you have a lot of experience. For other people, you have no experience, right? So this may seem too fast. And so my job is to try to kind of make sure that everybody's on the same page. And again, if you are one of those high-speed people and you want to know more, come talk to me. And if what I'm saying is not clicking, if it seems too fast, again, come talk to me. My goal is for everybody here to pass. Everybody should pass this course. I don't want to make it too difficult. It shouldn't be too difficult. But if you're having difficulty with anything in regards to what we talk about, again, come talk to me. I'm here for you guys. I want you guys to succeed in this course and then throughout IPATH. We're going to focus primarily on primary care because most of you, whenever you leave IPATH, you're going to be working in primary care. I know some of you are a guard and reservist, so you may go off and do more specialized things, but for the vast majority, you're going to be working in primary care, so we're going to try to cover things that you may see in primary care. Some things you're definitely going to see, other things maybe not so much. Maybe it's going to be one of those zebras with those rare occasions, but that's where the focus on it is. That's where the focus is. We're going to be talking about more primary care related topics. So with pathology, it's really, we're going to be talking about diseases, right? We're going to get into how these diseases form, and then once they form, how they impact our body, how they impact our cells, our tissues, and then once we're having some type of disease process occurring in our bodies, how do they present? How are your patients going to present? How are they going to come and say, hey, I got my knee's red and swollen? What does that mean? It can mean a number of things. So we're going to rely on our, what we learned here, what those signs and symptoms are, to try to figure out what's causing that disease in our patient to try to treat them. We will get into some treatment, a little bit of treatment. You're going to get more of that as you get into the actual courses that talk about those specific, like cardiology, pulmonology. But we'll talk about a little bit of treatment because you'll learn that there's more than one ways to treat one thing. So we're not going to get too in the weeds of that, but we will have some discussion on that. Hopefully you guys have access or were able to pull the PDFs or PowerPoints. I worked on it this weekend. I was kind of like trying to figure it out, and I think I did. So hopefully everything's up there. I put it in PDF for you guys. I put it in PowerPoint. I don't know how you guys study, so I like to use PowerPoints, but I know now there's all these kinds of cool apps out there where you can upload PDFs, so you have both options. If you try to click on block 2 or block 3, you'll notice that those aren't working quite yet. But I'm still kind of tuning them up, trying to make them, just change a few things up on there just for so I can teach you a little bit easier based on how I teach. But I hope to have those completed sometime soon. Definitely before you take the first test. So study tips, these are just some recommendations. This is actually from Mr. Weber. And this is what he found that kind of helped students as they were going through this course. So these slides aren't too long, I don't think. So if you briefly review them, and I'm not talking about studying them in detail, just kind of look and see what we're covering. Just so when you see it up here, when it pops up, it's not like the first time you've seen it. Ask questions during class. Please ask questions. If you don't want to ask a question, if maybe you're nervous or whatnot, come talk to me after when we have our breaks. You can talk to me after we're done. But if you ask a question, it might help somebody else who has that same question, and it helps myself kind of know what you guys are thinking. I'm not going to promise and say I have all the answers, but if I don't know the answer, I will figure it out for you guys and then let you guys know once I figure it out. Some of you guys have very good questions, and as I was sitting here last semester, there were some students who asked some questions I never thought of, right? So you got a lot of questions, and if you do, raise your hand, let me know, and then we'll try to work it together. After you guys get done with our classes, recommend you go back and review it. I remember though, when I was here, my focus is on the next test. And so I understand that sometimes we're looking at that first priority, but it helps you just go back and just quickly review it. That way it kind of stays fresh. But again, I know how it goes here. And then if you have any questions, whether it's in the night or we haven't seen each other for a few days, you can always email me. I put my number on the Canvas page as well, so you can always text me too. I do a pretty good job about responding. If you text me on the weekends, I will respond back to you, but it may be a little bit later, but I will respond back, especially on the weekends before the test. So I'll pay extra attention and make sure that I'm really checking my texts and emails for you guys. All right, so a little bit about me. I've been here for about a year. So I did Air Force has an education fellowship where you kind of learn how to run a PA program. So I did primary care though since I graduated from IPAT. I graduated in 2016, and then since then I've been working in primary care. So I have a lot of experience in primary care. I've seen all kinds of things there. But with the fellowship, they did teach some about like instructional method, but it was more so how a PA program is supposed to run. So if you ever want to learn about that, most of the services have that. I know Army has one, Air Force has one. I'm not sure about Navy or Coast Guard, but there's something certain. But it's a good opportunity. I never thought I'd come back here to teach. It wasn't something that when I was sitting in here in y'all's shoes that I thought about. But as I kind of went through primary care and kind of did different things in that aspect, I was like, why not? Let me see what happens. Let me try my luck out here. And so far, I've liked it. It's been very rewarding. So if you ever want to talk more about that, come talk to me about it. I know you guys probably aren't thinking that far in advance, but if you ever have any questions, come talk to me. Any questions before we kind of move on to our actual lecture? No? Let me see. All right. So kicking off, we're going to be talking about cell pathology, kind of starting at that lower level, and then as we advance through the course, we're going to definitely get into those higher structural tissues and different organs. We're going to talk about, and I'm not going to lie, I feel like this first part of the section is kind of a little dry because you've already had some of it. You've already had this in A&P, and then you had some biochemistry already. So maybe it's more of a recap for you guys. But I think it's necessary just to kind of make sure everybody's on the same page. So we'll talk about the normal cell, how cells get injured, and then when they start becoming injured or if there's some type of stressor to them, how our cells adapt, and then how cells die, right? Cells are going to die. We want them to die. They shouldn't live forever, but sometimes when they die too soon, that's a bad thing, right? So we'll talk about that towards the end. So pathology, it just means the study of disease. That's all it means. And like I already briefly mentioned, we're going to talk about what happens when we have that disease, how it's going to affect those cells, those tissues, how our patients present, and then based off how they present, how we're going to treat them. What we're going to do to diagnose that, if we're going to get labs, if we're going to get imaging. So this kind of builds that foundation for when you get out there and actually start seeing patients. So a normal cell. So our cells, as you guys already know, they have plasma membranes, right? We need those plasma membranes intact. If anything happens to that plasma membrane, that cell can no longer function. Everything has to stay within that. And if you think of it like a cell wrapper, something wrapping around the cell, it's kind of right, but it's more than that. Because those cells, they have the membranes, they have different types of structures. They have proteins, they have different types of carbohydrates, and the membrane's job is to actually help that cell get things into it and out of it. And we have this example of the sodium-potassium pump. You guys talk about that in biochemistry maybe a little bit? So normally we want our sodium to be outside of our cell, and we want our potassium to be inside the cell, right? It's very important for that to happen for different reasons, and you'll learn about that when you get into cardiology and neurology, but we need that kind of electrical gradient with the sodium outside and inside. But to do that, we need energy, we need ATP, right? And our mitochondria is what makes that. So if we have any drop in our ATP, for any reason, those sodium-potassium pumps are not going to work, they're not going to function. And when they don't function, well, that normally that sodium that wants to go from high concentration to low concentration is going to try to get into the cell. But when it does that, water likes to follow suit. Water likes to go into areas that have an area of high concentration. So remember that, because we'll talk about this a lot more as we get to the lecture. But we need that cell membrane. It's a living structure. And it requires energy, and we need that cell membrane to do what it needs to do in order for it to stay healthy. But problems can occur, right? If certain enzymes, if they get activated too soon, they can actually damage that cell membrane. And we'll talk about that. Medications, like Tylenol, in a healthy dose for a short period of time, that's fine. But when our body starts to break down large quantities of medications like Tylenol, it can make these metabolites that can actually cause damage to the cell and cause it to rupture. The complement system, we'll talk about that in block 3. It's part of our immune response. We don't have to, it's just there, right? But it complements our other immune system, our other immune cells. And then this concept of free radicals, I want to just make sure everybody's tracking this free radical thing, because I think it's important. So free radicals, all that means is that whatever atom, whatever molecule doesn't have a paired electron, right? Electrons like to be paired. I'm not going to go too much into biochemistry because I don't like biochemistry that much, but if there's an electron that isn't paired, that makes it dangerous, right? Because what those free radicals like to do is they like to steal electrons from other molecules. And when you start stealing electrons from other molecules, say like a DNA or a lipid or a protein, you can damage that. And one in particular, one type of free radical is the reactive oxygen species. And so our body makes that normally. It's a normal byproduct of how we make ATP, right? And it's good. We need that there. It's important because normally our body can actually get rid of that unless we have a high buildup of it or unless we can't get rid of it. Other things in our bodies make reactive oxygen species like our white cells, and they're important to kind of help destroy bacteria. Just keep that in mind. Reactive oxygen species, low level of them, totally fine. When we start getting high levels of these things, they can really cause damage in our body, and you'll see that here when we start talking about hypoxia. All right, nucleus. Everybody knows about the nucleus. That's where our DNA, RNA is stored, and that's the cell headquarters, right? That's what tells our body to make certain proteins, how to function, how to do certain things, and we need that there. We need our nucleus. We need our DNA in there. And if we have any damage to our nucleus, that's when problems start to develop. If the nucleus is damaged for whatever reason, some type of toxin, or maybe some type of UVB radiation, we can damage that nucleus, which can cause our body to make these inappropriate proteins, or cause our cells to grow and replicate when they shouldn't. So that's the basis really of a lot of cancers. There's some type of damage to the nucleus. It's causing some incorrect instructions, and as a result, we're getting this unregulated growth of our cells. We do have a block on cancer, and you'll learn more about that. Our cytoplasm, that's where everything's at, right? Besides the nucleus, that's where we have our organelles, like our mitochondria. That's where our Golgi apparatus is, and then you got some cystol, there's some fluid that kind of helps keep things separated, right? And I want to make sure you guys are tracking this. So with the cytoplasm, when a cell has an abundant amount of cytoplasm, so we have a small nucleus, lots of cytoplasm, that typically refers to what's called a differentiated cell. A differentiated cell, all that means is that it's a fully mature cell. So it's a fully mature kidney cell, it's a fully mature liver cell, it's a normal mature cell which is doing what it needs to do. On the flip side, we have these things called undifferentiated cells. And those are typical of our stem cells, which can kind of replicate into anything it wants to, but they're also characteristic of cancer cells. So when we get into that lecture of cancer, you're going to see, I'm going to show you some, and we'll see some here too in a minute. You're going to see how cells change their appearance based off what's going on with them. So a nice normal cell is going to have, like I said, small nucleus, lots of cytoplasm, that's good. A undifferentiated cell, a typically abnormal cell, if we're not talking about stem cells, it's going to have a pretty big nucleus, it's going to have very little amount of cytoplasm, and when we see that, we're able to say, hey, this is not normal, what's going on here, and then kind of do more testing to figure out what's causing that. Within the cytoplasm though, that's where we keep some of our enzymes, and you'll see here in a minute when we talk about the Golgi apparatus, but if those enzymes are in that cytoplasm, they're typically covered by this phospholipid layer as well. And that's important because we don't want them to be hanging around and trying to attack other parts of that cell, because if they do, they can actually damage them, right? But sometimes something occurs that can break that lipid that enzyme's in and cause those enzymes to actually kick off and start causing damage. And so that's a bad thing. We do not want that to happen. So just remember that when we start kind of talking about our other diseases. Does that make sense though? The differentiated, undifferentiated? Yeah, okay. So our mitochondria, that's where energy is made, right? That's where oxidative phosphorylation occurs. I'm not going to ask you to recite the steps in that process because you've already done that when you took biochemistry. But I want you to understand that if we don't have energy, if we don't have ATP, then that's where we start having lots of problems. Because like I already mentioned, that sodium-potassium pump, most of the structures in our body, they require ATP. And oxygen is needed to make ATP, right? And if we don't have ATP, things start to break down, cells start to not function normally, and they have the potential to die. And I have this example here of cyanide poisoning. So we don't run across that too much in primary care, thankfully, but it's an example of how if you impact one thing in that process of making ATP, now you're not going to make energy. And then as a result, your cells are going to start to degrade, they're going to start to not function normally, and it's going to cause cell death eventually. So cyanide chromatin oxidase, that's one of the steps, right? If we introduce cyanide for whatever reason, that cell may be swimming in oxygen. It may have plenty of oxygen, but it can't use it because the cyanide is impacting that one little step. So any impact to our production of energy is going to cause a lot of detrimental effects to our body, to our cells. Down below, we kind of already talked about that. So sodium-potassium pump requires ATP, requires energy to pump that potassium out of the cell when it's trying to diffuse into it. And if we don't have the ATP, water's going to follow into it. And if water falls into it or flows into it, what's going to happen, right? That cell is going to start to swell. It may not damage, it may not fully rupture, but if we don't fix the problem, if we don't include ATP somehow, then that cell is going to swell until it ruptures. And when a cell ruptures, that's where our body does not like to see the inside of our cells. If it sees parts of our cells that it doesn't normally see, it says, hey, something's off here, something's occurring here. Let's send our immune cells in there, let's see what's going on. And our immune cells, they're there to protect us, right? But sometimes they can go overboard and start causing damage to other cells that aren't affected. So we really want to keep the inside of our cells inside, not let our body see that, but if it does, then you'll see how that can impact our system. So the endoplasmic reticulum, think of that as the cell's factory. That's where the stuff is made. That's where proteins are made. That's where enzymes are made. I don't care if you guys know, like in the rough ER, that's where amino acids and proteins occur, and smooth ER. I don't care about that. I just want you to know that stuff is made there, right? It's also, in certain cells, it's also where we start to break down metabolites of drugs, especially in the liver. And I have this example here of the cytochrome P450 enzyme. You learned about that in biochemistry? Yeah. So if we, for whatever reason, tax our endoplasmic reticulum, it can cause issues elsewhere in our body. So for example, down below I have type 2 diabetes. So diabetes, it's a high sugar disease, right? And normally our body responds to that by making insulin. Well, that insulin is made in our beta cells in our pancreas, but that insulin is made in that endoplasmic reticulum. And if we are telling our insulin or telling our pancreas or beta cells, saying, hey, we have all the sugar in here, we need to get it into the cell, over time, those beta cells, that endoplasmic reticulum is going to burn out. We can't operate on overdrive forever. And once they start burning out, that's when our diabetes gets really, really bad because we can't make insulin anymore. We have to start prescribing it to our patients. So it's very important that we don't burn out that system. Same thing with alcohol. So alcohol in moderation, it's fine. But when you binge drink or when you drink too much, it can actually essentially deactivate that enzyme pathway that helps break down metabolites of other drugs. So that's why you've seen in maybe some prescriptions you've received or maybe a movie you saw that it says, hey, don't take this with alcohol. Because if we drink alcohol and take something like a benzodiazepine or some type of depressant, now our cytochrome P450 enzyme system can't break down those metabolites that normally they could, which causes a super therapeutic level of those drugs, which can really depress our nervous system and potentially lead to death. So alcohol, like I said, I think it's fine, but when you start mixing it with other substances and drugs, you run a real risk of potentially causing death to ourselves and our patient, right? All right, so then Golgi apparatus. So think of this as the cell's packaging center. So that's where all that stuff that the endoplasmic reticulum made, it goes to the Golgi apparatus. Golgi apparatus kind of wraps it up in these nice little vesicles and either kind of leaves it around the body or the cells when it needs to, or it sends it out to the cell membrane to get used somewhere else, right? Now, like I mentioned, those enzymes. We have enzymes, our ER is making those enzymes, or it's helping make those enzymes, and it sends it to the Golgi apparatus, and then our Golgi apparatus wraps it around. That way they're not exposed to other parts of our cell. And normally, or not normally, some enzymes, they require a kind of acidic pH, right? They work best in an acidic environment. Now, normally our system, our blood, our cells, they're a little bit alkaline. Normally it's about 7.35, 7.45, and that's great. It's protective. So just in case those vesicles rupture within the cell, it won't cause any issues because those enzymes work best in an acidic environment, some of them. But if there's damage to the cell, and you'll see here in a minute when we talk about lactic acid, if there's damage to the cell and we start making more of an acidic environment, if those membranes that hold those enzymes rupture, if they open up, well, now they don't know. Now they're like getting that on system. They're saying, hey, we need to get to work. It doesn't care that it's in your cell. It doesn't care that it's in your cytoplasm. It says, hey, I see a protein there. I'm a protease. I'm going to go destroy that. Or I see a lipid there. I'm a lipase. I'm going to go destroy that. So thankfully, normally, this doesn't happen too much. But it does have the potential to, if we damage our cells, cause some issues, especially if those enzymes burst open. All right, so cell injury. So we're going to be talking about different causes of cell injuries. Sometimes cells get injured, and if they do, they can revert back to a normal state if we catch it in time. Sometimes if we don't catch it in time, then it's irreversible. We can't bring it back and those cells die. We'll talk about how those cells actually get injured. Most of the time, The most common method is either low oxygen or low blood flow. And then we'll talk about this kind of strange phenomenon called ischemic reperfusion injury, which is really unfortunate because when our patients have some type of trauma-based type of heart attack, if you will, once we open up those vessels, we can run the risk of this occurring. All right, so reversible cell injury. So all that means is that there's some type of damage or some type of stimulus happening to the cell, and it's starting to impact the cell in a certain way. So the example here, low oxygen, right? We already kind of hit that. We talked about how that can impact our ATP production. But when that happens, we have a backup mechanism that can only last for a short time, and that's anaerobic glycolysis. And it helps, but it doesn't make as much ATP as normally, right? So if this occurs, if we're able to stop the injury, so for example, for this example, introduce oxygen back into the cell, then if it gets to that reversible cell injury point, it has the potential to go back to normal. But there's a certain point, there's a certain threshold that once we're past that point, that cell, there's no coming back. That cell's going to die, and when it dies, it's going to start leaking its contents. And I have this example here of these kidney tubules. So if you look at the normal kidney tubule, you can see it looks great. You can see the nucleus, you can see the membrane, the borders. Looks like a nice normal cell. When you get to that reversible injured kidney tubule, it doesn't look too great, right? But you can still kind of make out the nucleus. You can make out the borders. But if you go to the irreversible one, this looks all wonky. You can see it looks like it's kind of fading into each other. Some of the cells look a little thin. Some of them look like they burst, right? And if that happens, especially in our kidneys, right, there's no coming back. That cell most of the time is not gonna, or it can't revert back to normal, and that's when we start having these kind of chronic damages to our body. And I have this example down here too of our liver enzymes. So, and I don't think I talked about this yet. If you see an FYI on the slide, all that means is that it's just kind of more extra information. I'm not going to test you from FYI stuff. It's just more just to elaborate on certain concepts. So hopefully that helps you focus your study whenever you are studying. FYI, you will not see a test question on it, but it's just kind of there just to give you more information. But going back to liver, we have these enzymes in our liver, AST, ALT, LDH, and that can represent irreversible cell damage. Because like I said, when there's cell damage, when those cells become all the way damaged, they break open, they die, and then you, as the PA, when you're investigating that, you can draw their blood and say, oh man, you have a high level of ALT, something's going on with your kidney. What do I got to do next, right? Do I got to get an ultrasound? Do I got to get a CT? Do I got to get more labs to figure out what's causing that? So when you see that, think about irreversible cell injury, and that helps you as a clinician, as a PA, kind of figure out what's going on with the patient. All right, so what causes cell injury? There are a lot of causes, but if you see at the very top in red letters, right, oxygen deprivation, that's the most important, most common cause of why our cells get injured. And there's lots of ways that can happen. If somebody comes behind you and they put you in a chokehold, well, you have an obstruction, right? You're not getting blood flow, you're not getting oxygen into your lungs, and so over some time, that if they keep hold on that, we're going to start breaking down the cells because we're not getting that oxygen, we're not making that ATP. If we have pneumonia, we have an infection in our lungs. When that happens, we get a lot of fluid in our lungs. We have a lot of white cells, bacteria in there that are trying to help fight that infection. But it creates this blockage, if you will, to where oxygen can't diffuse from the alveolar membrane to the blood. So that can cause issues. If we have anemia, so we don't have enough red blood cells, or if we have ischemia, which just means we have reduced blood flow, again, maybe we have enough oxygen, but we don't have enough transporters to get that oxygen to where it needs to go, or maybe there's some type of blockage there that won't allow that oxygen to get where it needs to go. And then we talked about cyanide poisoning already. Again, not too common, but the big thing is that if we can stop that, if it's a short-term low oxygen state, then most of the time, depending on the cell, we can reverse that injury that happens. But if it happens for too long, if it's a prolonged state of low oxygen, then most of the time those cells are going to start to become damaged, they're going to die, and then we're going to get that irreversible cell injury. I got some other stuff down there below, like chemicals and infectious agents. We'll talk about that more when we get to other lectures throughout this course. But again, I want you to remember that the most common, most important cause is oxygen deprivation. So just some terms I want you to be familiar with. So we have hypoxia. All that means is that we have a reduced amount of oxygen. And it's typically systemic, right? Typically something's going on most of the time within our lungs where we're not getting enough oxygen to our body. We have anoxia, and that's the complete lack of oxygen. We don't typically use that word. I mean, you'll see it maybe in reports that you'll read or studies that you'll read, but most of the time we're talking about a hypoxia as opposed to anoxia. And typically with anoxia, it's more targeted to an organ system. So sometimes you'll hear like if somebody has a heart attack and their heart stops beating, their brain will become anoxic because they're not getting any blood flow to the brain. But most of the time in primary care, you're going to be running into hypoxia. And I got this example here of this baby. He or she is blue, right? And whenever we are hypoxic, we start to have this kind of blue hue. We call it cyanosis. And the reason why that happens is because deoxygenated blood has it doesn't have that as much oxygen, obviously, so it's going to kind of deflect that blue light, which causes our skin to become blue. It absorbs red light more, and then it deflects blue light, and that's why we turn a little blue. As opposed to ischemia. Ischemia, all that means is that we have insufficient blood flow to a tissue, to an organ. And most of the time that's due to some type of blockage, some type of clot maybe, or some type of plaque buildup in our arteries. But it's worse than hypoxia because not only are you not getting oxygen to those tissues, to those cells, there are other things in our blood that our cells need, right? They need sugar, they need proteins, they need amino acids, and then also we need to take what our cells make, those waste products, and remove them from that area because if they build up too much, they can damage our cells as well. So ischemia is worse than hypoxia because not only are you not getting oxygen, you're not getting nutrients, you're not removing those waste products. And when you start having all three of those kind of occur, our cells don't like that and start to become damaged pretty quickly. And if we have ischemia for too long of a time, that can lead to what we call an infarction, or tissue death or cell death. And there are a few reasons right for that. We've kind of already talked about it a little bit. If we have complete obstruction, we're not getting blood flow to the tissues, okay, well then those cells are going to start to die because they don't have oxygen. If we have a long-term kind of chronic ischemia, maybe those cells aren't dying right away, but over time, that low oxygen state is going to cause them to not work as well, and they can start dying then. And then if we have a sudden workload increase, so say we have an ischemic area, and all of a sudden we need a high level of oxygen, say we go for a run or go up a flight of stairs, now that baseline metabolism of where we normally function is no longer adequate because we need more oxygen, but we don't have enough to use. And this is an example of that. So if you look at this this picture here, you see this orange kind of half circle, that's our blockage. Before that, and this imagine this is a blood vessel. Before that, you got nice good blood flow, and those little green guys at the bottom, those are our cells, right? And the cells that are getting that good blood flow, they're happy, they're making ATP, they're getting their nutrients. But past that point, you got reduced blood flow. You have some type of blockage that's not allowing that as much blood to get through as normally it should. And the cells past that point, maybe they're okay. Maybe at rest, for whatever amount of oxygen that's getting through, maybe that's enough for them. But if you increase that workload, if you like I said, go up a flight of stairs or have to run or whatever, then now those cells need more oxygen. You're putting them to work, and now that blood flow that's getting through is no longer sufficient. And if that happens, that can cause that cell to go back to its backup mechanism to try to make ATP. And as we do that, we start burning that backup system out. The sodium potassium pumps fail, starts to swell, and then if we don't correct it, if we don't improve that, then those cells will swell so much that they burst, those cells die, and that leads to infarction, right? Cell death. And then going back to we're talking about this ischemic reperfusion injury. So this is what I was kind of briefly talking about when I first started the lecture. So say there's a blockage, right? Say a patient has a heart attack, there's a blockage in the coronary artery. Now those cells that are not getting enough oxygen, they're starting to swell, they're starting to become leaky. And when they leak, maybe they're not burst yet, maybe they're not swollen all the way in the lyse, but the inside of that cell is starting to leak its contents. And I already told you, when our immune system starts to see the inside of our cells, it says, hey, something's going on here, there's damage going on, we need to figure out what's going on here. But then on top of that, we start going back to our backup mechanism of ATP making. We start making lactic acid as a result, and lactic acid starts to build up these free radical precursors. So I kind of talked to you already about the free radicals. They're not free radicals quite yet, but if we introduce oxygen to them, then they can turn into free radicals and then cause issues if they are fully free radical species. And then we go and we open up that blood vessel, because that's what we should do, right? If somebody's having a heart attack, we need to open up that blockage. If we don't, the cells are going to die. We restore that blood flow, we put a stent in, or maybe we give them some thrombolytics which break down that clot. And then as a result, everything that was kind of past that blockage starts to kind of pour in. We bring in our immune cells, which start to see the inside of our cells. They say, hey, this is not normal. Why is there leakage coming out of these cells? And our immune cells get to work. They start to try to repair or actually try to break down those damaged cells, because now they're damaged. Our immune system is not like that. But it's not precise, because even though our immune cells are trying to control the damage, so to speak, they can start to damage other cells. They can start to damage normal cells, which causes more damage, more inflammation, right? We start to leak more insides of our cells, which causes more inflammation. And on top of that, you got this fresh oxygen coming through to this area that didn't really have much oxygen. That fresh oxygen is combining with those free radical precursors, and now you're making these reactive oxygen species, right? And I already talked about when we have these, they like to steal electrons from other cells, which causes more damage. So you get this kind of vicious cycle where we improve the blood flow, which is what we needed to do, but now we have all these inflammatory markers, we have these reactive oxygen species, which cause more damage, and it's this vicious cycle. So you'll see, like, if you ever treat a patient who had an MI, we don't just open up their blood flow and say you're good to go, right? We don't do that. We watch them, we admit them to make sure this doesn't happen. And when you get to cardiology, you'll learn we do other things when somebody has some type of heart attack, just to make sure that this is not what kills the patient. So again, kind of a strange dynamic. You would think once you open up that blood flow, the patient's good to go, but no, they're at risk for this type of injury, which can in the end potentially kill them. So. All right. You guys good, or you want to keep pressing? Good. Okay. So let's talk about cellular adaptation. So we talked about cell injury. When cells are injured or when some type of stimulus occurs to a cell, our cells have the ability to adapt. Sometimes it's good, sometimes it's not good. So cellular adaptation, you've probably heard of these terms: hypertrophy, hyperplasia, atrophy. Our body can normally go through this, but some diseases can cause a pathologic atrophy, hypertrophy. So it's kind of good to delineate what's normal versus what's abnormal. So atrophy, all that means is that there's either a reduced size of our cells, a reduced number of our cells, or some type of combination of the two. The cells aren't dead, they're still functioning, they're not working as well, but they're not dead. They're just either decreased in size or decreased in number. Physiologic, so as we get older, that's normal. Our muscles we're not as active as we were when we were younger, so our muscle cells start to kind of degrade. So you start to see atrophy in that. Pathologic, if anybody's ever broken an arm or broken some type of limb or been in a cast for a long time, or maybe you've seen somebody with that, typically what will happen if you don't use that limb, when you take it out of the cast, you're going to see that that limb is a lot skinnier, right? That's because it went through some type of atrophy because we weren't stimulating those cells to start working. We got hypertrophy. All that means is that the cells are enlarged, so there's not an increased number of cells, the cells are just getting bigger. And the only cells that can truly become hypertrophic are the heart muscle cells and your striated muscles like your biceps and the muscles of your limbs. Those are the only ones that can truly only grow in size. Then you got hyperplasia. All this means that there's an increased number of cells. So it's not like cancer where you have an increased number of cells. This is just some type of stimulus occurs. So for example, when women have their menstrual cycle, they get this estrogen and progesterone kind of influx that causes their inside of their endometrium, the inside of their uterus to expand to get ready for pregnancy. And that's normal. That should happen. But there are some medications that can cause hyperplasia as well. So you don't want that. And I have these examples here. So atrophy, that first upper picture on the right, that's normal. It's an older person. They're not as active anymore. So as a result, they start to develop atrophy of their muscles. Versus pathology, if you look at that picture of the hand, in the sulcus here, you see that divot, right? Something's going on there that's not innervating those tissues there to work. As a result, they start to get this divot because they are decreasing in size. Most of the time, that's typically due to some type of radial nerve pathology, maybe cervical nerve, but that's an example of pathologic atrophy. And we got hypertrophy. This is our bodybuilders, right? They're hitting the gym, they're working out, they're developing these larger cells, these larger muscle cells. And then we got pathologic, where we have this enlarged heart. An enlarged heart, remember this, we also call it cardiomegaly. So cardiomegaly can also be a term that we use for enlarged heart. And most of the time you'll see this if your patient has like high blood pressure and the heart's trying to beat against this high force. Well, like any muscle, right? If you work out a muscle for too long, it's going to grow. But if it happens in our heart, it can actually impede the blood flow in and the blood flow out, which can cause issues later on that we'll talk about, like heart failure or sometimes the heart can rupture, right? We talk about the hyperplasia, so the endometrium, again, going through a normal menstrual cycle. It's normal for the endometrium, that inside of the uterus, start to grow a number of cells, but then if it's not fertilized, then it's gonna degrade, and then that's when you have your menses. And then down below, that's gingival hyperplasia. So we used to use a medication called phenytoin for seizures, and one of the side effects was that hyperplasia of the gingiva. We stopped using that for the most part for seizures. Some people still do because there are better drugs out there, but that was a known side effect of that medication. That's the type of a pathologic, a non-normal hyperplasia. All right, so then moving on to different types of adaptations. So metaplasia. So metaplasia is an orderly transition from one cell to another cell. And what that means is that it's not changing cell types, right? So for this example down here, we got epithelial cells, epithelial squamous cells turning into epithelial columnar cells. There are still epithelial cells, but what's happening here is that there's some type of stimulus occurring to the cells where it's like, hey, the type of cell I am right now is not the best for this environment. So then it goes through this transition where they turn into these cells that are still epithelial cells, they're just a different type of cell. They're not cardiac cells, right? They're not cervical cells, they're still epithelial cells, just a different type. And you'll see that classically when you have chronic reflux, when you have chronic GERD, because what happens is, so our acid in our stomach should be in our stomach. It needs to be there, we need it to break down foods. But when we have too much reflux, that acid can go into our esophagus. When it gets into our esophagus, it can damage our esophagus. And so what our body does is say, hey, we're normally squamous cells, which are good typically when we're eating food, but because I'm getting all this acid in, I need to change because I'm getting too much damage. And so they metaplaze, they change into these columnar cells that are typically in our stomach. But if we continue that stimulus, continue that damage, they can turn into dysplasia, right? Dysplasia sounds bad. Right? This is not a good word. And we normally refer to that as precancerous. So before something turns to cancer, most of the time, you're going to get this dysplasia. And these cells, they look abnormal. They look, they don't look like normal regular cells. And I'll show you a picture here in a minute. But the problem with dysplasia is that, so with metaplasia, if we stop the injury, we stop the insult, those cells can go back to normal. Those cells potentially can go back to normal cells, and then, hey, we're good to go. With dysplasia, it's not always reversible. And the problem is that we don't know if the dysplasia is going to go into full cancer, what we call malignant neoplasia, or if it will go back to metaplasia. So when we have dysplastic cells, it's frustrating because what do we do with that, right? Do we just remove those cells because they potentially can turn into cancer, or do we watch it and make sure it doesn't? So it can be very aggravating to you as a clinician, as a PA, because when you have that occur, you have to figure out the best way to approach it. Now normally if you see this, you're going to have specialists involved for whatever the condition is, but it can be aggravating to the patient because now they're worried. Imagine you being that patient and being told that you have precancerous cells. It's going to scare you, right? So that's just something that you got to be careful for, you got to watch out for, because we don't know if that dysplasia will go back to metaplasia and actually back to normal cells. So I have this example down for kind of talking about the esophagus, the chronic reflux. So we have Barrett's esophagus, that's the condition, right? And if you're looking at this first picture here, that's us looking through our esophagus down into that what we call lower esophageal sphincter, right before we get into our stomach. And if you see here that kind of darker pink tissue, that's our normal columnar cells, should be there. And that lighter pink tissue, those are our squamous cells. On that picture in the middle, that is not normal, right? Look how that darker pink tissue is kind of going up the sides there. Those cells are now becoming metaplastic. They're changing into that metaplasia. And potentially with Barrett's esophagus, if we don't correct that, if we don't fix that, we can't figure out how to calm down that acid reflux, and potentially those cells can turn into dysplastic cells, and then eventually esophageal cancer. And if you were to take a biopsy of that, if you kind of go in that junction where you have that abnormal tissue versus normal tissue, you can see on this kind of picture on the right, the cells, even though they're changing, they don't look too irregular. Maybe you don't know what that looks like quite yet, but this looks pretty, you can still see the nucleus, you can still see the borders, as opposed to dysplasia. This is an example of dysplastic cells of the cervix. This is when when women get their pap smear, this is what we're looking for. We're taking cells off their cervix and we're sending it to a lab to look at the cells and make sure that they're not turning into dysplasia or cancerous lesions. And if you look at that cell at the very top, that's a normal cell. It's a differentiated cell. It has a small nucleus, has lots of cytoplasm. That's good, that's normal. If you look at the ones with the arrows, look how small those cells are. Look at the nucleus, they're pretty large. You don't see much cytoplasm around that. So these are dysplastic cells. And they potentially, if we don't treat them appropriately, potentially can turn into cancerous cells and cause cervical cancer. And then these questions here, I left them in place. These are from Mr. Weber when he taught this. These are just some questions that he got that other students had, and they're just more elaborate. So again, I'm not going to ask you any questions on this per se, or at all, not per se at all, but it just kind of helps just fill in some of the gaps. Trust me, you're going to get this. You're going to get a lot of this when you get to women's health your senior semester. You're going to know how to treat cervical dysplasia. But for now, just kind of a little bit of information for you, just in case you're curious. All right, so let's go ahead and take a break now. We'll do about 10 minutes. So meet back up at. It's in there.
So it'd be like the same route where I could do it. I was it's like tear down. Right here, right here, like the one. Apparently, they have announced they have one in yeah, they have one right here. I know we're going to I'm enjoying the best life right now. So I was like, do this. Wait, what did you do? I told her
oh yeah. I have this like my hairs don't go and they always try to pull it out. So I look like Star Boy.
So she was like, let me
Yeah, now that I'm like, no, I just like to think of it and stuff like that. But like they don't like to do that because it's just like we won't pay as much. So they places that have been they're like, oh, you don't have to Is that thing like critical like my this and my this I like my yours like that's where the world is at how wait, where? I'm on it's by the bridge. Do you get like
It's right across the street.
Almost done here. A few more slides to go. All right. Any questions about what we talked about? Anything come up? Guys clear? Okay. So kind of moving on, so now we're talking about cellular death. And like I mentioned before, cells are gonna die. They should die, we want them to die, but when they die in a certain manner, it's not good. A type of cell death, a normal type of cell death, what we call apoptosis. Apoptosis is normal programmed cell death. We have these genes within our cells that say, hey, it's time to die, you've lived out your life, you did what you needed to do, now it's time to break down and make room for new cells. And when this happens, this isn't a clean process. Our cells die, and you'll see a picture here in a minute, but it doesn't trigger inflammation. So remember how I told you guys that when our body sees the insides of our cells, it starts to cause inflammation? This does not do that, because what happens is our cells have this method to when they start to break down and die, they kind of wrap themselves around this phospholipid bilayer, which kind of puts it in this nice little trash bag, so to speak. And then our white blood cells come along and they engulf those trash bags, those wrapped membrane cell pieces, and get degraded. And that's good, that's normal. Now if our cells didn't die, so if you look here at our white blood cells, if we had too many white blood cells, that is a bad process. And that does happen for some people, and we call that leukemia. That's a type of white blood cell cancer. Syndactyly, so if you see these fingers here and these toes, during fetal development, It's a normal part of development where the webbing between our fingers start to break down, right? Those cells start to die. We need that because if we didn't, we'd be walking around with these kind of enclosed claw-like hands. Sometimes there's a failure of that due to some type of issue, but most of the time that works well, but it's a normal process, right? Some cancer drugs, they kind of use that to their ability to enhance cancer cells to die genetically. We're not going to get to cancer treatment, but just know that that's how some cancer drugs work. But again, it's a clean process, it's orderly, there's no inflammation with this process. Now necrosis, that's different. That's when cells die prematurely or naturally. When that happens, we don't have these nice little wrapped cell piece membranes that we get with apoptosis. These release the insides of our cells, and then like I said, our body sees that and they're like, hey, what's going on here? We need to come, we need to figure it out. We need to start that inflammatory process. Now, I keep saying inflammatory process. We're going to talk about this a lot more tomorrow when we talk about inflammation. But just know that inflammation is good, but sometimes it can cause other issues. There's different types of necrosis. Coagulated necrosis, that's the most common form. And what that means is that there was some type of acute episode of low oxygen for a tissue or an organ, and the inside of that tissue or organ starts to die. And when it starts to die, it coagulates. Kind of like if you ever cooked an egg, right? If you ever cooked an egg, the inside of it's a lot firmer. That's coagulated proteins. That's what happens here. And the reason why that happens is because those enzymes, they also need oxygen, they need ATP. When we cut that oxygen off to those enzymes, they can't break down that dead tissue. And so what happens is you got this organ, and if you were to look at it from the outside, it would look nice and normal. If you were to cut the inside of it, you would see that there's these coagulated dead cells. I'll show you a picture in a second that is no longer functioning. Then we have liquefactive necrosis. This is where tissues start to break down and dissolve. They kind of get this gelatinous, kind of watery appearance. This most often occurs in our brain, because in our brain we have a high lipid content. We have lots of lipids there. We also have these microglial cells. You don't have to know that, but those cells, those microglial cells, when the tissue in our brain is dead, they can actually break down those dead cells and cause this type of liquidy appearance to those, kind of break them down and it causes liquidy appearance. You'll also see that in our abscesses. So has anybody ever seen an abscess or treated an abscess before? Yeah? So you've seen where, and you will eventually, all you will, trust me. But when you have an abscess, you essentially, typically though, most of the time they occur in the skin. They can occur elsewhere within the body, but most of the time we're going to see it in the skin. But we have some type of infection in the skin. Our body says, hey, there's some bacteria here. We need to kind of wall this off. We need to protect it. We need to stop this bacteria from getting outside of this area. It sends our immune cells, our neutrophils, our white blood cells to kind of kill that bacteria. And when it does that, those neutrophils, they release enzymes that start to break down the bacteria, but they also start to die, and they also start to break down other tissue. And as a result, you get this kind of liquidy, pus-like discharge from infections of our skin. And then the last one is caseous necrosis. So caseous, it's Latin for cheese-like, and it looks like cheese. And I'll show you that here in a sec. And this is most common with TB, tuberculosis. You'll see it with some other fungal infections, but TB classically presents with this caseous necrosis. And what happens here is that TB, as you learned probably in micro already, TB is very hard to kill. Our body can kill some TB, but most of that TB is going to kind of hang around because it developed these kind of mechanisms to prevent it from dying, right? So if we can't kill it, the next thing we're going to do is try to wall it off, right? We make these walled off, these walls of just white blood cells that are called granulomas, and in that, our white blood cells are releasing their enzymes, trying to phagocytize the TB bacteria. They're killing some of them, but then they're dying in the same process. They're also damaging other tissues as they're trying to kill these TB bacteria. And as a result, you kind of get this mix of dead white blood cells, dead TB particles, dead tissues, and they kind of mix together and has this kind of crumbly, cheese-like appearance. And again, this is most typical with TB, some other funguses as well, but most of the time, especially when you're taking your cancer, if you see casus, whatever, they're probably talking about TB. Hopefully one of the answer choices is TB. So just a kind of diagram of apoptosis and necrosis. So if you look here at the bottom, apoptosis, that's the clean process. I told you, our cells say, hey, it's time to die. Let's go ahead and die. We're going to wrap our insides, or the inside of our cell with these membranes, and our white blood cells are going to come and they're going to start eating that. Clean process, no inflammation. As opposed to inflammation, our cells are dying. They're dying prematurely though. We're not wrapping them up in these nice little wrappers, and so when our body sees that, it's going to start that inflammatory process. It's going to kick off and then potentially cause other issues within our body. Here's that example of different types of necrosis. So the casus, this is a picture of the heart. We kind of cut it in half. Now you're looking at it from the top, right? But if you were to look at it from the side, it would look nice and normal. But us cutting it in half, you can see that kind of thin yellow streak. That's that coagulated necrosis. That's those proteins that kind of built up. Our enzymes weren't able to break them down, so we get this coagulated mass of tissue. As opposed to liquefactive necrosis, this is a brain cut in half as well, and you see this divot, and you can see it kind of looks a little shiny, kind of looks a little wet. That's that liquefactive necrosis. So those enzymes were able to break down that tissue, and now we got this divot there, but we also got this kind of liquidy type of leftover. And that last one, that's that casus necrosis. So that whole black thing is the lung, and then that yellow part, that's that cheese-like appearance. That's that caseous, those caseous dead cells that just kind of crumble up and cause this typical appearance. And then gangrene. So I want to point out that gangrene, all that means is it's just a clinical description of necrosis. We call it a gross description, not because it's gross like it's nasty, but when you see something visually, you can grossly see it, right? It's not a specific type of necrosis, so it's not a, like I told you about coagulative and liquefactive, there's no such thing as gangrenous necrosis, but you will see in some textbooks and in some papers you read that sometimes it's referred to as gangrenous necrosis, but it's not its own type of necrosis. If you were to take a biopsy of gangrenous tissue, you would see that it can either be coagulative necrosis or liquefactive. So it's not its own category, okay? Now, typically, this is going to involve our lower extremities, and we'll see this sometimes with people who have like bad arterial disease in their lower legs, or diabetics who have this plaque buildup in their arteries of the legs, and they get some type of damage to their feet. And you'll learn that with diabetes, if we have too high of a sugar content, it can actually destroy our nerve cells. And so then our patients, they have this infection in their foot, not know it, and then this can build up and start causing damage to the skin and the deeper layers. But dry gangrene, all that means is that there's no infection there. And it looks black, it looks shriveled up, it looks mummified. So if you look at the toe on your right, if you kind of get down to the base of that toe, if you were to take a biopsy of that, it would probably be most likely coagulative necrosis. Now, if you go a little bit higher and you kind of go to that edge where you got this yellow kind of outline and you got that red, that looks infected. It looks infected because it's a little bit wet looking, right? There's redness around that upper part, which tells me that maybe there's some type of infection kind of spreading. That is what we call wet gangrene, and all that means is that tissue is infected. That necrosis, or that gangrene is infected, and that's more of that liquefactive necrosis. Very similar to our abscess, right? There's our white cells are trying to fight off this infection, and so as a result, we start kind of breaking down that tissue and get this liquidy, watery appearance. And the last thing here, so pathologic calcifications. So when cells are damaged, we can get something called dystrophic calcifications. So when a tissue is damaged, when a cell is damaged, it kind of acts as the soil for calcium in our blood to grow there, stop there, and start to precipitate and grow larger. So when you see calcifications in maybe an X-ray or maybe a tissue biopsy, all that means, if it's dystrophic calcifications, that there was damage there. That damage acts as a soil for calcium to deposit, and it's just a way to say, hey, there was some type of damage here, maybe sometime in the past. But if you were to take a blood sample from this patient, you would see that they have normal calcium levels. So even though there's calcium depositing into these tissues, because it's related to damage, you're going to see normal blood calcium levels. As opposed to metastatic calcifications, this is the opposite. You have normal healthy tissue, but the problem here is that you have too high of a blood calcium level. So when your blood calcium is too high, it can precipitate out into tissues, normal tissues, so you kind of get this widespread calcification kind of seen throughout the body. And this only really happens in conditions that cause very high calcium levels. For example, hyperparathyroidism. We'll talk about that I think in block 3 when we talk about endocrinology disorders. But what happens there is that the parathyroid, that controls our blood calcium. And if there's some type of tumor there, it can send a signal to our bones, to our osteoclasts in our bones to break down calcium, or break down our bones, which increase our calcium level. And then another condition called multiple myeloma, we'll talk about that when we talk about blood cancers. That's a specific type of cancer of our plasma cells. They too can tell our osteoclasts to break down a lot of bone, which can increase our calcium level. But again, the tissue is normal, there's no damage there, it's just that our blood calcium is too high, and as a result, it precipitates out to our normal tissues. Cool. That's it. That was the first block, so hopefully it wasn't too terrible. Tomorrow we'll talk about inflammation, which is a little bit more interesting, I think, but that's just, does anybody have any questions about what we talked about today? Cool. All right, thank you guys.